Welcome back to another episode of Lifetime Talks. I'm David Freeman.
And I'm Jamie Martin.
And in this topic, we're going to be hitting on high functioning depression and strategies for reclaiming joy. In 2020, Dr. Judith Joseph noticed that despite her success as a psychiatrist and researcher, she was overwhelmed and exhausted, yet dissatisfied and restless, and often teetered between the fatigue and the relentless drive to keep busy. She noticed a similar phenomenon among many of her therapy patients. The go-getters, the high achievers, and the super reliable types in her practice were at best feeling meh about their accomplishments as a whole, and they typically felt guilty about not doing enough. This led her to her research, which she now refers to as high functioning depression, and also develop a 5-step plan for reclaiming joy.
Yeah, we're super excited to have you on the podcast, Dr. Judith Joseph. You were also recently on a cover of Experience Life magazine. How are you?
Great. Thank you for having me. It's so good to see you again.
Good to see you. Well, I just want to read a little bit of your bio. You have an amazing list of credentials. We're going to get just a little tight one here, and then we're going to dive right into questions with you. But you are a world-renowned psychiatrist and researcher who specializes in mental health for children and adults. You have conducted the first study in the world on high-functioning depression, which we're going to be centering our conversation around today. And your peer-reviewed study is the basis of your best-selling book, High Functioning: Overcome Your Hidden Depression and Reclaim Your Joy. You also have some specialties in women's health. You've been part of, you taught the first masterclass series on menopause alongside Halle Berry and other experts in 2024. We could go on, but we're really excited to have you on with us and to talk about your book and just this really important topic that I think is affecting a lot of people. I know when I read High Functioning before I met you in person, I was reading it going, "Oh, I relate to a lot of this. I feel this in my own life." And so I think it's one of those things that as I've talked to more and more people, they're just resonating with it and feeling like they're actually feeling seen when they hear this phrase come up.
Yeah, a lot of people are like, okay, now I have a term for what I'm experiencing.
Mhm.
And I do a lot of work in terms of educating the public and so forth. And one of the things I recently learned was that when people search for how they're feeling, they don't put in terms that mental health professionals use. Like, for example, if I were to talk to a colleague, I'd be like, oh, is the person depressed? Are they anxious? But when like the real people put in search terms, they put in things like, why do I feel weird? Why do I feel off? But like in the mental health community, we're looking for things like, are you depressed? Are you anxious? So there's just this huge disconnect. So when I started talking about a lack of joy and this term called anhedonia, people were like, oh my gosh, there's a scientific term for when I feel off, when I feel weird, when I don't feel like myself. Because, we're all built with the DNA for joy. It's our birthright as humans. So if we're not feeling joyful, if we can't grasp joy, that's a problem.
Yeah, absolutely.
And even within the actual bio, it ends up speaking to you had to go through this experience yourself to be able to speak to it. And just thinking of that as far as a person that is actually practicing this and also helping people with it, you always can now speak from that experience. So if we just break down that definition and more, get our listeners even more connected to you as far as share with us your experience and what exactly that high functioning depression looks like.
Yeah, so clinical depression, the term that is in most medical literature, it happens when you have all these symptoms of depression. So you have symptoms like sadness, but some people don't have sadness. Some people have anhedonia, which is a lack of joy, pleasure, and interest in things that they once enjoyed. And then there are more symptoms like low energy, problems with your sleep, problems with your appetite, concentration problems. All of these symptoms on a checklist. And in the very bottom of the checklist, you have to check this final box of these symptoms have led to a loss of functioning or an impairment, a significant impairment in functioning, or these symptoms lead to distress. But what I was finding was that a lot of folks were coming in after 2020 having all these symptoms of depression. And then at the very bottom of the checklist, they weren't, losing functioning. They were actually over functioning. They were overworking. They weren't saying they were in distress. They were saying they felt nothing. They felt meh, bleh. So there was really nothing for these folks. And I found myself saying, okay, well, when you lose functioning, then come back.
Mhm.
And I thought, like, why are we doing this in mental health? And my colleagues who went to medical school who are cardiologists. They're not saying, "Oh, let's wait until you have a heart attack and then we'll do something." They're saying, "Let's prevent the cardiac risk."
Mm.
My friends who are, gynecologists aren't saying, "Let's wait till your hip fractures. Let's start the hormonal treatment to prevent the hip fracture," right?
Mhm.
And if a doctor who's a cancer doctor said, "Oh, let's come back when you're stage 4 cancer," you'd be like, "Where'd you get your medical degree from?" Right? You'd
Right.
question them. But in mental health, we're still in dark ages. We still wait for you to break down and then we react. And I thought, why are we doing this? And it was when I was sitting at my desk giving a talk to this massive hospital system. And then halfway through that talk, I was like, wait, I think I'm depressed. And it
Mm.
snuck up on me, that feeling of anhedonia, that meh, bleh. I thought if it could sneak up on me and I study this and I treat this for a living, I wonder how many people out there are experiencing this and they don't even know if there's a term for it. And so that led me to start studying this. I wrote up a protocol where we enrolled patients who had all these symptoms of depression, but rather than breaking down, they actually overfunctioned. And rather than shutting down, they couldn't sit still. They were like these busybodies who were coping with their pain by busying themselves.
Mhm, mhm.
And it was the first peer-reviewed, published study on high functioning depression in the world. We weren't even aware at the time until the review board said, "Oh, we couldn't find any other study, so yours is the first in the world."
Mm.
And when we started to talk about it and educate the public, people were like, "That's me. I just didn't know there was a term for it."
Mm.
Yeah, and I think when you and I met a few months back, I mean, you mentioned that this still isn't in and now I'm not gonna remember the DSM-5, it's not
Yes,
defined in there, correct? Right? But it's still
yes.
something that you're finding so many people are dealing with. What is the prevalence of HFD? Like, I'm gonna refer to it as HFD going forward
Mhm.
just to tighten it up. Do you have ideas based on your research, like how many people are dealing with it?
We don't because I did the first study, but since I've published that study, a lot of universities around the world have reached out to me.
Mm.
People from Europe have visited my lab, Asia, they're starting to do these studies. But when you look at typical depression, I mean, we can look at all of those studies that are done because there's like a massive amount of literature.
Yeah.
Depression's quite common. Um, you know, in some studies it's as common as like 1 in 5 people. In other studies, 1 in 10. It's really difficult to determine the exact number, but it's a pretty common.
Right.
And what we do know is that depression is more common in women versus men.
Mm.
Women are twice as likely to have depression, twice as likely to have anxiety compared to men. And so, again, some people question even that data because a lot of men won't say they're depressed. Women are, acculturated to talk about their emotions. A man may experience depression, but come home and knock back 3 beers and then yell at his family and go to bed, right?
Mm.
And never get diagnosed because we're looking for sadness, we're looking for crying, we're looking for people expressing depression, but men express it differently. So, that's why determining the exact number can be challenging, but we do know it's very common. High functioning depression, I think, is more common because I think a lot of us walk around wearing this mask of pathological productivity. We don't know how to acknowledge and tap into these emotions we're humans doing instead of human beings. And in my study, what I found was there was a high correlation between unprocessed trauma, unprocessed pain, and HFD. And the theory is that, folks classically, when they have a painful experience, for example, looking at PTSD, most people would say, I don't want to see the person. I don't want to be in the place. I don't want to even be in a situation that reminds me of it. Those are my triggers and they make me shut down. But the theory is that with high functioning folks, they don't want to deal with the pain. So rather than avoiding people, places, and situations, they just avoid dealing with it by overworking, by
Mm.
busying themselves. So you ask them, how do you feel when you sit still? They feel empty. How do you feel when you're not working? They feel restless.
Mhm.
And that's the difference. I often get asked, like, how is that different than burnout? And I usually show I have this model of the brain in my office where it's like, I usually show this model to patients, but like literally, like, this is the brain in the workplace. And a burnt out brain in the workplace has all the stressors from the workplace, right? Like all the environment's causing you to feel low motivation, fatigue, irritable, anhedonia, sadness, because burnout is an occupational hazard by definition. It's a workplace causing the symptoms. So you remove that person from the workplace and those stresses are gone, they start to feel better.
Mm.
High functioning folks, they're in the workplace. They still have the stressors. They have those symptoms I talked about. But the difference is that when you remove them from the workplace, they don't get better.
Mm.
It's not the external environment causing the symptoms. There is something inside the individual that it's an internal process that hasn't been done. It's an internal lack of processing, the pain that hasn't been done. And that's what's causing symptoms. That's why even when they're out of work, they don't feel better. So that's the difference between HFD and burnout.
Yeah, that
Yeah,
makes sense.
and
Good.
within that same vein, yeah, just understanding that the brain reference that you showed, I want our listeners, one, first for you, if you can, before we start to talk about the influence, and then obviously the ambition of the burnout here. When we say big T and little T, as it relates to trauma, and then how that sits within our mindset and our memories. So let's define that real quickly, and then I'm going to follow up with a little bit more to elaborate on that. So big T and little T, how would you define that for our listeners?
Well, traumas, according to that DSM, which is the Diagnostic and Statistical Manual for Psychiatric Conditions,
Mhm.
basically the Bible of psychiatry, trauma as defined there, which leads to PTSD, has to be like a major, like life-threatening event
Okay.
or an assault. Like, think about combat, think about someone getting attacked,
Okay.
right? There are these really, significant events that are either life-threatening or is extremely, um, triggering, right?
Okay.
But many people experience little t traumas, which are don't make it into that book, right? So things like not having food when you grow up, being neglected by a parent, being verbally abused by a partner,
Mhm.
losing all your money in a bankruptcy, right? Like, these are very traumatizing things, but they don't meet that nice little box within the DSM for trauma. And so, many times in my PTSD research, when I bring a patient in, and we're going through the DSM, we're looking at trauma, and they say, "Yeah, I had an ex who belittled me all the time, withheld finances from me, and made me, excluded from my family, and they just alienated me, and it was very traumatizing." I have to say, "Well, that sounds very painful, but you don't meet criteria for trauma." And they're like, "What?"
Mhm.
Right.
Because according to that very neat criterion in the DSM, that's not considered a trauma.
Mm.
But in the real world, that is a trauma, right?
Yeah.
Right.
So I define traumas in general as experiences that are so significant that they've shaped you and how you view yourself in the world, how you interact with others, right?
Mhm.
And that encapsulates a lot of painful, significant experiences, not just the big T's.
Mm.
And so I created this more expansive inventory because after doing years, again, of this research and then having to turn people away and then off the record saying, "I believe you," but on the record, that's not a trauma. I felt like I had to create a more expansive inventory for trauma. So things on my trauma inventory are things like, you know, have you ever been excluded because you look different than
Mhm.
someone else? Have you ever been in a situation where you didn't have food to eat? Have you ever been in a situation where someone literally verbally belittled you and
Yeah.
made you feel like you were nothing, right? These are all things that are painful. And in the real world, we'd never say that's not a trauma. We'd say, "Oh my gosh, that's terrible."
Right.
But in the scientific world, we'd say, "I'm sorry that happened to you. That doesn't count." you know?
Yeah.
So I wanted to keep all these things in that inventory and include the big T's and the little T's.
No, I love that, and thank you for explaining that. I think of the accumulation of all the things that you just said, whether it's the big T, obviously it's there, and then you have the little T's, these little accumulations over a lifespan. And then I got to reference the movie like Inside Out. I just think it displayed such a great way of how to one connect to emotions, but the core memories was a part that stood out to me in that movie. With that, when you look at the big T and the little T's, these core memories, and then I remember you just displaying the brain for those who are watching. I want to understand now. This can be something that might have happened at an early age, but then does not show up again until teenage years or maybe in adult years.